Online. So,
Good afternoon, Dr. Sandeep.
Good afternoon, madam.
Yeah, and Dr. Anita. We are meeting for the first time.
Yeah.
Yeah, we are just getting set up. We
Yes.
will get started briefly. We are waiting for some IAP delegates if they are around to make some introductory
Yes, ma'am.
remarks before we get started. So be another 5 minutes.
Yeah. So, shall I share my presentation or I'll wait, madam?
We can get we can do that and set it up so
I
that
suggest,
we
I,
do
I
not
suggest,
have to waste much time after we
Yes, I
get
think.
started.
yeah, ma'am, you can just test it, ma'am. Once we can
Shouldn't
just
have
test
much
that.
hassles. Just to make sure it's okay.
Yes.
You can stop sharing. We will
Is it
get
okay?
started up there.
Are the
Yeah,
slides?
it's fine.
Okay, good.
Yes,
I'll stop sharing, madam.
it's thank you. I'm just waiting for Dr. Athar also to just make a screen share check. Mr. Saji, have you intimated the president and president-elect? Anybody is likely to come?
Yes, ma'am. Yes, ma'am. They're joining.
Thank you.
Yeah. Yogeshwar is traveling. He may join, but I've informed others.
Okay. I can see Dr. Basaraj. Good evening, Dr. Basaraj. I think Dr. Basaraj, you're muted. You'll have to unmute yourself. Saji, it works that way, right? They can unmute themselves when they want to talk. Good evening, Dr. Basaraj.
Yes, ma'am. Yes, ma'am.
Yes, it is 4 o'clock. We were waiting for it o'clock 4 before we get started, and I think I'll go about the introductory conversation. I can notice some of the IAP delegates over here. I will get started. Good evening, everyone. I am Dr. Vanita, your host and moderator for today's CME. I would request everybody to mute themselves.
Good
Mr. Saji, you
evening.
can check on that.
Good evening. Good evening.
Good evening, Doctor.
Yes, Dr. Vasan.
I was just getting started.
No
Welcome,
issue.
doctors.
Yeah, you can go ahead. Actually, we are at Delhi. No issue. You can go ahead.
Very kind of you to join
Thank
in
you.
despite your schedule, Doctor.
No.
Okay, this is I'm Dr. Vanita. We are hosting monthly CMEs in Bahrain in coordination with IAP with a new theme every month, and today's theme would be concepts in neonatology. I welcome Dr. Vasant and Dr. Basuraj to give some introductory comments before we get started. Dr. Vasant, please go ahead.
Yeah. Good evening, all. Actually, thank you, Dr. Vanita, Dr. Basavaraj, our past president. I think our president-elect, Dr. Neelamu, is also going to join, and Yogesh is there. We had 3 consecutive meetings today at Delhi, 3 conferences, you can say. So I attended all that, and just I am in airport. So it's all academic events are going. It's really is a good thing that we are having a collaboration, and today's topic is neonatology. That's we are doing literally really lot of work for that. Basically, NRP, National Neonatal Resuscitation Program in India, and that to be basically for health worker. So they are getting till now. You might be knowing that 2,000 health worker we have trained till now, and more and more are going to through our NRP program and our neonatology after of Indian Academy of Pediatrics. So definitely we should have, I think, one physical meeting also either in India or Bahrain, wherever possible. We can discuss in length everything, not only neonatal, everything. Thank you, and wish you all the best. Thank you.
Thank you, Dr. Vasant. We have such plans. We can discuss that on a different platform. Thank you very much. Dr. Basuraj, please, a few words from you. We cannot hear you, doctor. I think you're muted or you'll have to increase the volume.
डॉक्टर बसवराज आवाज नहीं आ रही है आपकी.
Hello.
Mr. Saji,
Yeah,
you
yeah,
can help.
yeah.
Yes,
Can you able
doctor,
to
we
hear me
can
now?
hear you.
Yeah.
Yes, sir.
Yeah. Thank you very much, Dr. Vanita, respected our National President, Dr. Vasant Kalatkar, and President-elect Dr. Neelam Mohan, Professor Yogesh Parikh, our Secretary General, and Datanu Badra, our Treasurer, and all the OBEB. So, this is one of the program which has been going very well academically, which has been started by American Mission Hospital along with Indian Academy of Pediatrics. Thanks to Dr. Ranjan Pejawar and Dr. Vanita, who has been taken in one of the most important topic, that is a neonatology. Neonatology is a thing which is very much required. We have seen in the last 3 decades. So there is a big change of things which has been happened in the neonatal program and the care. So, and neonatal resuscitation is also one of the things where the India is a pioneer in that work also. So I'm sure that today's faculty, which is led by Dr. Sandeep Kadam, along with Dr. Athar, I personally I know both of them very well. So I'm sure that today's academic bonza is going to be in a very interesting. Best wishes for the today's program, Sandeep and Dr. Athar. So looking forward to listening to your conversation.
Thank you. Thank you, Dr. Vasant and Dr. Vasaraj. I'm just waiting if I can have a few words of insights from Dr. Neelam as well. As always, she would be present
I
for
think
such
no, she
events.
might be traveling. She might be traveling. So Dr.
Okay.
Yogesh is there. Whether Dr. PC, Dr. Yogesh is there.
Yeah,
I did not see Yogesh.
Okay. Okay, you can
Yeah,
continue.
I-
You
Most
can
probably he's
continue.
traveling.
yeah,
Vasant.
we get
Yeah.
Dr. George Cherian, our CEO neonatologist, would also apologize. He wanted to be on the event as well as Dr. Ranjan Pejawar is traveling in US at the present moment, and he has also apologized he wouldn't be able to attend today. Okay, as Dr. Neelam joins, we'll have her join us to give us some introductory comments in between. In the meanwhile, I guess since it's time, we are getting started. As I initially started, our theme today is concepts in neonatology. I'm Dr. Vanita. I'll be your moderator today. The topics are concepts in neonatal sepsis with case presentations that would be presented by Dr. Sandeep Kadam from IAP. And Dr. Athar would also talk about another vital pillar of neonatal care, the golden hour. Both these concepts are, as I said, vital pillars of neonatal care. And there have been challenges, dilemmas, and lots of research. And it's for us to see today what are the developments that we have to catch up with, and then how we can apply in our practice and the challenges that we face, how Dr. Sandeep and Dr. Athar can delineate it for us for modifying our practices. I do not see Dr. Athar at the present moment, but I had a word with him. He should be joining. In the meanwhile, I think we'll get started with the
I'm here,
first
Dr. Vanita. Good
presentation.
evening.
Good evening, Dr. Athar. Okay, we are all set. Now we'll get started. I would introduce Dr. Sandeep. I think both of you are familiar with each other. Let me introduce you to each other, Dr. Sandeep and Dr. Athar, neonatologists in their respective places. I would introduce briefly about both of them in the due course of time. Now, the first topic is concepts in neonatal sepsis via case presentations to be discussed by Dr. Sandeep Kadam. Dr. Sandeep Kadam is an eminent neonatologist hailing from India and from the MD Pune, and he is a professor and a neonatologist from KEM Pune. He is a neonatologist for past 20 years, is what I get to understand from his CV, and he has various publications to his credit. I invite Dr. Sandeep Kadam to get started with the CME. Dr. Sandeep,
Yeah.
you can please go ahead.
Good evening, everyone. Am I audible?
Yes, doctor. And the slide share is also perfect.
Yeah, so respected IAP dignitaries, Dr. Vasant Khalatkar, President, Dr. Basavaraj Sir, Dr. Yogesh Parekh, Dr. Neelam Mohan Madam. Well, I take this opportunity also to thank Dr. Vanita and Dr. Ranjan Pejawar Sir, who have been instrumental in me being here this evening with all of you. So also I would like to thank Dr. Mohammad Salman and taking this initiative to be with all of you this evening. Well, what we are going to do today is discuss about neonatal infections, uh, case-based discussion. I thought we all know that we treat sepsis in India as well as outside, right, left, and center, and most of us do every now and then we treat this in common conditions. My slides, yeah. So we all know that what is neonatal infections or sepsis. It is classically defined as a clinical syndrome which is characterized by signs of infection frequently accompanied by bacteremia. Commonest diagnosis that we give our babies from the NICU at discharge is probable sepsis, clinical sepsis, culture proven sepsis, culture negative sepsis, and this is all the time that we have been seeing. Though in the last few years, the incidence of sepsis has come down, the severity of problems are going down, but we all see infections day in and day out. And the commonest presentation that we see in our practice is sepsis, meningitis, pneumonia, osteomyelitis, though rare now, arthritis, urinary infections, probable sepsis, so many other things that we see. But our common diagnosis that we give to most of our babies has been neonatal sepsis. So just before I start, what is proven sepsis? Any baby who has got a positive blood culture or PCR nowadays that we are using, which has grown some organism and baby has some signs and symptoms, is proven infection. Whenever you don't have a culture which is positive, it is probable infections. And possible infection is raised CRP with interleukins, cultures are negative, baby has some clinical signs and symptoms, it is possible sepsis. So basically these are some of the terminologies which we use interchangeably, but I think what we need to understand is that it is culture proven and culture negative infections that we need to understand. Well, I'll start with my first case. Now, this is a 34 weeks preterm baby. The mother had history of preterm premature rupture of membranes for 30 hours. This mother had maternal tachycardia. There was fetal distress, hence a emergency cesarean section was done. Baby cried immediately. The birth weight was 1.7 kilos. This baby had respiratory distress. Now the issue is the baby was transferred in view of prematurity, respiratory distress, and the mother had history of PPRM. So do you think we should start antibiotics? What will we do apart from NICU care? So will you start antibiotics? Which antibiotics? Whether we should do any investigations? Is there any role of doing a CRP on day one? Whether we should do a blood culture and how one would monitor in this baby? So obviously, if you see, this baby was a 34-weeker and this baby had a history of leak in the mother, and the baby had signs suggestive of respiratory distress, and there was possibility that this could be an early onset infections. So whenever you have a baby who is a preterm, there is a risk factor in the mother in the form of PPROA, maternal UTI, and this baby has been symptomatic. Well, the first thing that we should do is take a blood culture and start antibiotics. Yes, we would start CPAP, we would give IV fluids, we would do a supportive care, temperature, monitor the baby for hemodynamics, do a blood sugar, keep the baby warm. But the caveat here is that preterm babies, risk factor in the mother, one should start antibiotics. Even if the baby is preterm and the mother has some risk factor, the baby may be asymptomatic, one would still start antibiotics, wait for the blood culture. I think we all need to start having that culture of taking a blood culture. I think that is my first message. And in premature babies, one can't wait. And if the baby is symptomatic, we should start antibiotics. So what are the risk factors for early onset sepsis? Well, it is PPROM, that is preterm premature rupture of membrane, which is more than 18 hours in preterm and more than 24 hours in a term baby, mother. Chorioamnionitis, as we all know, that it is mother with foul-smelling liquor, maternal tachycardia, high CRP, abnormal WBC count, lower uterine tenderness, and along with it, positive CRP. So that is chorioamnionitis, which was previously called as chorioamnionitis. Nowadays we say it is intraamniotic infections. Mothers with UTI and maternal fevers. These are some of the risk factors which puts a baby at risk of infections. In our own country, this was a systematic review which looked at risk factors for neonatal sepsis in India, and it is a male baby, outborn babies, need for mechanical ventilation, preterm, and preterm premature rupture of membrane. So these are some of the risk factors with the odds of developing infections in the baby. So one would look at these risk factors, and if there are any of these risk factors, then we should do a blood culture, start antibiotics, and look at the baby more closely to see if there is any worsening as far as early onset sepsis is concerned. So my first message today is, if you have a baby in the NICU which is unwell, the baby is sick, we make a tentative clinical diagnosis of neonatal infections, take a blood culture and then start antibiotics. So we need to take a blood culture before starting antibiotics and not take a culture after starting antibiotics. The second message, which is very important, is that we are all obsessed with this investigation called as CRP, and I think there is no role of CRP to start antibiotics. Please remember that, don't justify that CRP is high, that's why I have started antibiotics. If you have a baby who is unwell, please start antibiotics, because CRP may take 18 hours, 24 hours to come positive, and one CRP alone, it is not significant that there is infection, because you may have some of the non-infectious causes which can give a high CRP, like you may have meconium, sepsis, you may have hypothermia, you may have surgical problems, asphyxia, sometimes other problems which can give you a positive CRP. So high CRP is not equal to neonatal infections. So don't do CRP to just say that I have diagnosed sepsis because the CRP is high. CRP has got a very good negative predictive value. Does not have a good positive predictive value. So a specificity of CRP, that is, if the CRP is negative, say two CRPs are negative 24 to 48 hours apart, then we can say that the probability of infection is less.
Oh.
Don't take CRP as a positive marker for infections. Second case, term baby, mother had leak for 36 hours. So this was a prolonged rupture of membrane. There was no maternal fever. There was no foul smelling liquor. The baby was born. Baby cried immediately after birth. The baby weighed 3 kilos and the baby was absolutely normal. There was no distress. There was no problems. Now in this case, should we start antibiotics? So obviously this was a term baby, mother had received antibiotics, and the mother was totally asymptomatic apart from risk factor for leak. So if you have a baby who is asymptomatic, there is no need to start antibiotics in a term baby. One could wait, watch, observe. So please remember that waiting and watching and monitoring is very important. If the baby has any symptom or any sign to suggest that the baby is unwell, we need to take a blood culture and start antibiotics. Mother treated with antibiotics is reassuring. There is no role of doing a cord blood CRP. So my second message here is, if you have a term baby, risk factors in the mother, asymptomatic baby, please wait, watch, observe. Mother treated with antibiotics, I would observe, and it is reassuring. Mother untreated, I would observe, start antibiotics if it is unwell. So again, the message here is, if a term baby, the probability of early onset sepsis in a mother with risk factor is less. Coming to the next case. Sorry, I think there was, yeah. There was one slide which missed. Okay. Now this was a baby who was born preterm, and the baby worsened at 23 hours of life. The baby was off colored. There was tachycardia, there was tachypnea, there was a core peripheral temperature more than 3 degrees. The baby had shallow extremities, and there was a diagnosis of shock that we made. This was a baby born at 29 weeks. The baby's weight was 1.2 kilo, and there was obviously no risk factor in the mother, but there was shock which presented within the first 24 hours. So we made a diagnosis that this could be early onset infection. And what we thought was, sometimes the maternal history may not be taken well. Sometimes we may miss, there was mother with fever, there was a leak, there was a mother who had urinary tract infection. So it is very important that we dig the history properly. Look at the placenta. If there was any foul-smelling placenta, if there was any evidence of suspicion of chorioamnionitis, we need to send the placenta for histopathology, take a blood culture, start antibiotics. So by early onset infection, we are looking at transmission of infection from the mother to the baby, and this is a vertical transmission. So what is early onset? It is from the mother to the baby. It is vertical transmission, and the risk factors may be present in many of the cases, so we need to take a clear history. Look at the maternal flora. Now, organisms may be different in the different parts of the world. In our own country, in India, it is predominantly gram-negative infections. It is E. coli, Klebsiella, it could be Pseudomonas acinetobacter. So it's predominantly gram-negative. Whereas in the developed country, it is group B streptococcus. So there are different organisms, and the antibiotic policy may vary from place to place and NICU to NICU. So we need to have our own surveillance, our own flora to look at the antimicrobial sensitivity and the flora that we are growing in early onset infections. Previously, we used to say that the cutoff for early onset infection is 72 hours, which is most widely accepted. But in very small babies, it can be taken as 7 days. And many of these babies who have got early onset infections often present with respiratory distress, and it is a generalized problem. They may have temperature problem, they may have off-colored, shock, hypotension, they may be having sugar imbalance. But I think one needs to understand that it is a generalized problem and not a localized problem, and one needs to take a blood culture and start antibiotics. Coming to the next case. Now this was a baby born at 34 weeks, preterm delivery, weighing 1.6 kilo. The mother had PIH. The baby had cried immediately after birth. It was a section done. There was no risk factor in the mother for sepsis. The baby had minimal tachypnea, admitted in the NICU for prematurity and low birth weight status. So issue here, should we start antibiotics? Now, just because the baby had mild tachypnea, just because the baby had mild tachypnea, baby is low birth weight, baby is slightly preterm, most of us tend to start antibiotics because the baby may be having possibility of early onset sepsis. Mind well here, there is no risk factor in the mother for infection. It was a clean preterm section which was done for maternal indication. Now, if you look at the WBC count which was sent on day 1, the WBC count was 3,300 and the platelets were 36,000. Now, please remember that there was leukopenia, there was neutropenia, there was thrombocytopenia. Now, day 1, low platelet is not equal to infection. That is my next message. So, early onset thrombocytopenia on day 1, look at the mother. It could be a mother who having PIH. Now, this PIH probably caused leukopenia and neutropenia. So, there is no role of giving prophylactic antibiotics in newborns admitted in the NICU. So I think we need to understand that we should not treat the reports. We should look at the baby, and we should treat the baby. If the baby has symptoms, signs suggestive of early onset sepsis, yes, we are justified in starting antibiotics. Otherwise, there is no role of treating just because the WBC count is 3,300, neutropenia, leukopenia, thrombocytopenia. Now, this was possibility due to PIH in the mother, so we need to look at the mother. So if you have babies who are admitted in the NICU, there is respiratory distress, but the mother does not have any risk factors, the baby does not have any signs and symptoms suggestive of infections, I think we need not start antibiotics. So well baby, low platelet, low WBC on day 1, look at PIH. Now, what are the clues that can give us information regarding starting of antibiotics? If you have early onset shock, so baby presented at 2 hours with shock, with respiratory distress. It could be intrauterine infection, fetal SIRS, early onset sepsis, eye discharge, conjunctival discharge, basically foul smelling cord, foul smelling baby, pustules, placenta which was foul smelling, the baby was warm. So these are all the signs and symptoms suggestive of early onset sepsis. Then one would start antibiotics, and mind this probability of early onset sepsis in these babies is very high. So take a blood culture and start antibiotics. Now the next case is 32 weeks preterm, 1.4 kilo, admitted for RDS. Baby was ventilated, received surfactant, extubated to extubate. Can I request all of you to please mute yourself? Hello, can I request all of you to mute yourself, please?
Actually, they have been muted by the administrator.
Yeah. Now this baby, this baby was ventilated, received surfactant, and the baby was on non-invasive ventilation. Now, as usual, this baby was quite sick, so the umbilical line was secured. Baby was on TPN. Baby was treated with amoxicillin and clavulanic acid as a part of probability that the baby was very sick and received amikacin. On day 3, this baby was off-colored. The extremities were dusky. There was weak pulse. Also the baby had bounding pulses. There was tachycardia, increased precordial activity. Point of care echo done showed a PDA. Now see, remember that this PDA probably caused the baby to go into shock. It may mimic infections, and this baby probably would be better off receiving paracetamol or ibuprofen. Then the baby had posturing. There was pallor, weak pulses, asymmetric popliteal angle. Ultrasound done showed grade 2, grade 3 IVH. So if you have asymmetric popliteal angle, look at the pupil, look at the fontanelle, and this baby may have IVH, which will look as though the baby has sepsis and shock. So what I would like to make a point here is, if you have a baby who is looking unwell, not responding to antibiotics, we keep on grading up the antibiotics from piperacillin to meropenem to colistin to tigecycline, and thereafter we have left with no antibiotics. So please, every time you grade up an antibiotic, review the diagnosis. It could be a PDA, it could be IVH, it could be a congenital critical heart problem like a hypoplastic left heart, or it could be a coarctation of aorta, or sometimes inborn errors of metabolism, neonatal encephalopathies. So all sick looking babies are not necessarily sepsis. So I think this is very important to remember, that babies who look unwell, who are not responding to antimicrobials, we keep on grading up the antibiotic after antibiotic. I think it is time that every time you grade up the antibiotic, please review the diagnosis, and you will be shocked that sometimes in a while, once in a while, you could pick up a coarctation, or you could pick up adrenal hemorrhage, or it could be an inborn error of metabolism. This baby subsequently on day 12 reached full feeds, but then developed abdominal distension. There was apnea, there was yellowish aspirate, there was blood in stools. Obviously, the diagnosis was that there is a neck. There could be a late onset infection. What next? Well, we would keep this baby nil by mouth, do a septic workup, do CSF, do urine culture, send a hemogram, start antibiotics, and the baby was receiving meropenem and amikacin. The blood culture was negative. There was no response to meropenem. The blood culture was showing Klebsiella, not negative, but the platelet counts were low. So a decision was made whether we should start colistin, but there was no response. What next? So this was possibility that this was a multi-drug resistant bug. There was and there was a late onset infection. And what are the risk factors in late onset sepsis? It could be invasive ventilation, it could be long lines, multiple antibiotics, TPN, prematurity, and smaller babies. In fact, if you look at one of the data, the risk factor for NEC and risk factor of late onset infection is higher in those babies who receive antibiotics in the first 7 days. Anytime you give antibiotics for more than 72 hours, the risk of late onset sepsis and NEC increases. So what is LOS? It is infection from NICU to the baby. That is from you and me and the nurses, and from the NICU instruments into the baby. And that is horizontal mode of transmission, which is late onset sepsis. So having looked at early and late onset infection, the next question is, how long do we give antibiotics? Well, clinical sepsis, as I said, cultures are negative, sepsis screen is negative. Stop antibiotics if the culture is negative. Suspected sepsis, one needs to stop antibiotics if there is clinical improvement and the biomarkers are negative. So one could use CRP, and 2 CRPs 24 to 48 hours apart negative with a negative blood culture, and the baby is well, one should stop antibiotics. Culture proven, infections 10 to 14 days, meningitis 3 weeks, complicated meningitis 4 to 6 weeks in the form of ventriculitis or brain abscess, urinary tract infection 10 to 14 days, bone infections 4 to 6 weeks. So this is what we are looking at, duration of antibiotics as far as NICU and neonatal sepsis is concerned. But we are all the time obsessed about antibiotics, and we know that we overuse, abuse, and misuse antibiotics, and that basically is because we are afraid that the baby may develop infections, and that is an innate response for all of us as neonatologists to give antibiotics. What are the hazards? Well, if you give antibiotics, it can cause gut dysbiosis. So normally we all know that a normal preterm gut or a term baby should have lactobacillus and bifidobacterium. And when we use such higher antibiotics, these bacteria are killed and they are replaced with all abnormal bacteria or abnormal flora from the NICU, which is predominantly the E. coli and Klebsiella and Acinetobacters. and they are going to inhabit and colonize the gut, and they will migrate from the intestine into the circulation and cause late onset sepsis and NEC. There's increased risk of NEC, there's increased risk of fungal sepsis, there's increased risk of multi-drug resistant infections. And most important, because your good bacteria are dying, these babies end up getting feeding intolerance. It increases the cost of care, and it has been shown that overuse of antibiotics is associated with wheezing and hyperreactive airway diseases and atopy. So basically, these are the hazards that we have started seeing because of overuse of antibiotics, and we really are left with very little choice of antibiotics because of these multi-drug or pan-drug resistant organisms. So then comes the concept of antibiotic stewardship. And what is it? It is a set of activities that promotes the right selection, the right dose, the right route, and the right duration. So basically, we all need to follow this antibiotic stewardship in order to minimize the menace of multi-drug resistance and have a culture of getting and stopping the antibiotics at appropriate time. Well, we go on to the next case. This was a term baby, outborn, presented with fever on day 12, treated as sepsis, blood culture showed Klebsiella. The platelet count was 22,000, total WBC count was 2,300. So here we have a baby who has LOS, Klebsiella sepsis, thrombocytopenia, leukopenia, neutropenia. This baby also had a big liver and a big spleen, sick looking, received meropenem and colistin. Now, after 7 days of antibiotics, there was no response. What next? Now people say that one should grade up, maybe give tigecycline, give ceftazidime, maybe Bactrim. But what are the possibilities and what is the way forward in such a scenario where we often see these situations where there is a Klebsiella, pan-drug resistant, and the baby just is not improving? Well, we evaluated this baby had very high CRP, very high ferritin. Echo was normal. There was persistent fever, splenomegaly, cytopenia, bicytopenia, hypofibrinogenemia, and hypertriglyceridemia. So this is a case of hemophagocytosis with hyperferritinemia. Now here we need to understand that neonatal HLH, though rare, is once in a while seen. So whenever you see a baby with unexplained fever, unexplained organomegaly, and bicytopenia or pancytopenia, think of HLH. Most of our hemophagocytic lymphohistiocytosis are secondary to infections. They may be also underlying prolonged TP and prolonged malignancies. Primary HLH is rare, and in this situation, we saw that this was probably a familial hemophagocytic lymphohistiocytosis, which is autosomal recessive condition. So we need to look at some of the newer modalities of diagnosis, like a genetic diagnosis of whole exome sequencing in a baby who is not responding with multiple antibiotics. Look for HLH as one of the differential diagnoses. Coming to the next case, a male child presented on day 24 with prolonged jaundice, feeding well, absolutely normal. Baby's birth weight was 3 kilos, today's weight was 3.4. The lowest weight that the baby had gone was 2.7 kilos. There was no pallor, there was no hepatomegaly, no splenomegaly. Thyroid was normal, bilirubin was 14. So this baby on day 24 had a indirect hyperbil. It was a direct fraction of less than 1 with neonatal unconjugated hyperbilirubinemia, and we thought that this was a prolonged jaundice. So what we did was we sent a urine culture and it grew E. coli. Baby was treated with antibiotics. Ultrasound showed there was a retention of urine after post-void, and we did a MCU which showed a PU valve with reflux. This baby underwent cystoscopy, valves were percurated, baby went home, discharged, and the jaundice disappeared. So what is my message here? So whenever you see a baby with neonatal jaundice which is prolonged, look for the underlying UTI. There may be congenital malformations, occult infections, often will present as prolonged neonatal hyperbilirubinemia, which is unconjugated jaundice. Next case is a 29-weeker, 800-gram, very preterm baby, was treated with for RDS, received surfactant, ventilated, extubated on day 9, received CPAP for 10 days. This baby had feeding intolerance, repeated x-rays, showed abdominal distension. There was, just because the baby was quite small, and IUGR, recurrent sepsis workup done was negative. The baby had mild jaundice, platelet count was low, 45,000. Baby received multiple antibiotics, received antifungal, there was no response. We made a diagnosis that this was probably a culture negative sepsis. And what do we do? So basically this was a preterm SGA, well but not looking very well. Baby was off colored, persistent thrombocytopenia, feeding intolerance, cultures were negative, think beyond infection. The urine gave CMV, cytomegalovirus infection. So this was probably a CMV infection, was treated with valganciclovir. In these cases, one should do a Head ultrasound, one should do a BERA or AABR and look for hearing impairment. So looking at torch as one of the differentials, maternal history is often absent. Look for occult markers in the form of IUGR, low platelets, organomegalies, pneumonia, encephalitis, blueberry muffins, hepatosplenomegalis, and once in a while you may end up seeing that this baby probably also has a cataract or chorioretinitis. So a very high index of suspicion is required to pick up torch infections in NICUs. The next baby is a 28-weeker, 800-gram, born to a mother with PIH, had abnormal Dopplers, recurrent feeding intolerance. A central line was inserted, TPN was given. Baby received antibiotics for 14 days in between for a episode of late onset infection. There was persistent thrombocytopenia. There was a big liver, big spleen. And on day 34, this baby was still oxygen dependent and their baby had persistent thrombocytopenia. So what is it? We treated for late onset sepsis. Baby had a big liver, a big spleen, and there was persistent low platelets. So we thought that this probably was some gram-negative infection, whether there is something else going on in the baby. And we had worked up for HLH. Nothing came positive. The cultures were recurrently negative. So in view of thrombocytopenia, hepatosplenomegaly, and persistent oxygen requirement, sepsis screen was sent, CRP was normal, blood urea was 86, creatinine was 1.8, and ultrasound showed that there was a hyperechoic lesion in the right kidney suggests a fungal ball. Urine screening showed a budding yeast, which was later proven that this was a case of candida in the urine and candiduria grown in the culture. So whenever the baby received amphotericin and the baby responded well. So whenever you have an infection which is not responding to antibiotics, the first thing is to review your diagnosis. Maybe your diagnosis is wrong. Then look at the antibiotics, whether it was a wrong choice, wrong dose. Look at complications in the form of HLH, fungal infection, CME infection. And once in a while, it could be an immunological problem, immunodeficiency. Primary immunodeficiency is not uncommon, especially if you have consanguineous history. Previous sibling died of some recurrent infection. So we need to take our histories well and we could get a clue about primary immunological problems. The next baby is a 33-weeker preterm 1.4 kilo baby born with LSCS. Baby had RDS, treated for probable sepsis. On day 5 had feeding intolerance. Blood culture was sent. Baby was started on antibiotics in the form of piperacillin and amikacin. On day 7 it grew Acinetobacter. Probably this could be a nosocomial infection. There was resistance. Antibiotics were changed as per the sensitivity to cholesterol. On day 14, the baby was but the hemogram revealed a platelet count of 8,000. We gave one platelet, repeat platelet after 36 hours, 5,000. Now here issue is that the baby, though looking well, had severe thrombocytopenia and one is worried whether it would bleed. So people tend to give IVIG, give platelets, look for fungal infections, look for CMV, look for whether there's any bone marrow suppressions, so on and so forth. The baby was stable, tolerating feeds, and we removed the PICC after 13 days of duration. And after 72, the platelet count started improving. So whenever you have a persistent thrombocytopenia and the baby is not responding, remove the long line. This could be a long line related issue. Now, some of the practices that we tend to do is we really don't do lumbar puncture that commonly. And when should one do LP? So whenever you have a baby who is unwell, has evidence of infection in the form of apnea, jaundice, abdominal distension, fever, irritability, bulging fontanelle, seizures, encephalopathy, all babies with late onset infections and early onset sepsis with clinical manifestations, and anytime you have a culture proven infection, we should do a LP. And how do we diagnose meningitis? Normally the cell count outer limit is 30, 60% of them may be polys, proteins up to 170 is normal, sugar up to 119 is normal, but CSF to blood glucose ratio should be normally more than 50%. So look at all these parameters, but most important, send a blood culture and see that your cultures, whether they are growing any organisms. So the gold standard is obviously a culture proven diagnosis, but sometimes you may not get cultures which are positive, especially if the baby has received antibiotics. So we should be looking for meningitis, a very high index of suspicion. Do LP if you are in doubt in all babies with LOS, that is late onset sepsis. Early onset sepsis, if there are symptoms, and any baby with culture proven infection, we should do lumbar puncture. If you don't do LP, you miss a meningitis and the baby develops a complication of meningitis in the form of ventriculitis or hydrocephalus, it would be painful. A word about sepsis screen. We were taught about Philip, that was IT ratio, WBC count, CRP, micro-ESR, and any 2 out of 3 positive would be a positive sepsis screen. And recently there was Jerdis, which is leukopenia, IT ratio more than 0.2 and a positive CRP. Any 2 out of 3 positive is a positive sepsis screen. So my next message is, don't use sepsis screen to diagnose infection. It has a very poor positive predictive value. The predictive accuracy of a negative sepsis screen increases to 98 to 100%. So sepsis screen should be used to rule out infection and not rule in infection. So please remember that the utility of sepsis screen is to say that this baby is unlikely to have infection when the sepsis screen is negative. So this is the message as far as sepsis screen is concerned. No baby of infection would get well unless we look at the supportive care, nutrition, and very important, you give mother's own milk, standardized feeding protocol, give HMF, monitor growth, calculate the proteins and calories in your day-to-day round, so that unless and until we provide adequate nutrition in the form of standardized feeding, mother's own milk, colostrum painting, use KMC to promote and get more mother's milk, because that has shown to improve the outcomes in our NICU. So what are the strategies that we need to reduce infections in the NICU? KMC, hand hygiene, cord care, colostrum painting, minimal invasion, and use bundles in the form of WAP bundle, CLAPC, and there could be a role of probiotics in our NICUs. So to summarize, what we discussed in the last 35 to 40 minutes is a very important tool to diagnose infection is good history taking. Whenever you see an unusual sign, symptom, unusual finding in the course of a neonate, think of sepsis. Clinical sepsis, start antibiotics after taking a blood culture. But most important message here is stop antibiotics as early as possible. There is no role of giving antibiotic just because the baby is ventilated. There is no role of giving antibiotic just because the baby is admitted in the NICU with minimal tachypnea. Meconium, don't give antibiotics right, left, center. There is no role. So stop antibiotics as early as possible, because today we are left with very few choices of antibiotics. Sepsis should be the culture of neonatal intensive care unit, and it is very important that we should prevent infection rather than treat infection. So what are the carry home messages? Don't look for sepsis in NICU, look for sepsis. I think that is very important. Spend more time on your nurses, teach them education, take help of your microbiologist. Hospital acquired infection prevention should be our key, and for that we need to have good housekeeping, good NICU design, good protocols, and teamwork. The future of NICU in wherever we are, whether we are in Bahrain or India or US, is asepsis and prevention. We need to have own audit and surveillance, and quality care is the key to success. So thank you very much. Let us talk of asepsis more than sepsis, and I would like to thank all of you for giving a patient listening for this presentation. Thank you so much.
Okay, Doctor, that was a very crisp walkthrough of various case spectrum that we encounter in neonatal sepsis. Please hang on there for the questions from the audience and a discussion after the next presentation. Whilst we move on to the next presentation, thank you very much, Doctor. So we'll come back to you again. Before I go to the next presentation, I would like to make an announcement. We could not get the CME points from NARA. This is for the local Bahrain CME credit information. We could not get. So this is an announcement from the team that worked towards getting the CME points. I just wanted to make an announcement in this regard. Okay, whilst we move to the next presentation, as has been highlighted by the first presentation walkthrough in neonatal care, always challenges us with the outcomes, and bundle care, as in healthcare of many other systems, has proven to be, debatably proven to be, giving us good outcomes. One such would be the golden hour strategy of neonatology. So we will hear from Dr. Athar more about it. Dr. DrAthar Mujeeb is a neonatologist in Bahrain. He's the consultant neonatologist in King Hamad American Mission Hospital. I would like to invite Dr. DrAthar to join in whilst we move on to the next presentation. Dr. DrAthar, the floor is yours.
Thank you, Dr. Vanita. Yeah, uh, thank you to IAP post holders for arranging this session since last 6 to 8 months. And thank you, Dr. Vanita, to giving me opportunity for this topic. And thank you, Dr. and Professor Sandeep, for very interesting case scenarios, especially the one with came out as HLH, which is usually we don't think very frequently in an ICU. Now I'll go to my topic. Am I audible clearly?
Yes, doctor.
Hello?
Please go
Yes,
ahead.
okay. Yeah, so I'll go ahead.
Slide share is good, audibly is good.
Excellent, excellent. So my topic for today's discussion is a very important topic we call golden hour, or also first 1 hour of after the delivery of the baby. So my agenda for today's presentation with what is golden hour, the concept, what are the implications, what are the key concerns for a preterm baby in first hours of life, what things to be do, how frequently, what time is allotted for each intervention, and what are the individual components of golden hours. So if you'll see, there are a few goals in neonatology. First, as most of us we know, golden minute, the first 60 seconds after birth of baby. The purpose is to assess and establish resuscitation. Then we have golden hour, which I will be discussing today. First 60 minutes, interventions done in first 60 minutes have a lifelong implication for the baby. And then another new concept recently also came for extreme preterm babies are golden week, which focus on optimizing care during the first week of life in the form of respiratory care, nutritional care, and cardiovascular care. So what is this concept? This concept of golden hour was adapted from adult trauma. As they have seen that initial first hour of trauma management has a significant decrease in patient mortality and better outcome, which concept was in adult trauma was given by Dr. Adam Cowley. And the in neonatology, it was first published as a quality initiative study by Regina Reynolds in 2009. The golden hour care of the low birth infant during the first hour of life, their unit experience, they found various significant improvement in the mortality and the morbidity after using this as a quality initiative. This was the first reported study of golden hour in neonatology. So it is a time, first hour is a time of profound and critical transition for the babies. It introduced, as I told by Regina Reynolds in 2009. The first hour has significant impact in the neonatal outcome. What is the definition exactly? It is you have to perform a certain evidence-based interventions in a systematic, sequential, and efficient manner within first hour of life. That is the definition of golden hour. It should be evidence-based, preferably non-invasive, in a sequential way to rapidly stabilize a unit. So why we need the golden hour concept for extremely low birth weight and very low birth weight babies? Because they have temperature issues. They cannot maintain their temperature. Poor respiratory drive can go into apnea. They have surfactant deficiency. Their poor energy stores can go to hypoglycemia. They are often a product of a complicated delivery. They have immature adaptive system, and all these leads to they are susceptible to intraventricular hemorrhage and periventricular eclampsia. And also the family, premature delivery is like a shock to the family. It takes time to get adjusted to understand the situation, what's going on. So what are the key concerns? Immediate concerns are temperature related, low blood sugar. If you did not do proper resuscitation, baby can be hypoxic, or if you use too much oxygen, hyperoxia, blood pressure issues, respiratory failure. These are the immediate concerns. If these are not managed properly, then we have long-term complications like if the hemodynamic stability was poor, ventilation was inadequate, baby can have intraventricular hemorrhage, they can have bronchopulmonary dysplasia, necrotizing enterocolitis, retinoperimetry. These are the indirect complications of uh, inadequate management in the few hours of life. So how do golden hours progress? What are the stages? One stage comes prepare the case before delivery based on the history. then manage in the delivery room or the operation theater, then manage transport, and then care in the NICU. So what is the timeline they have? So there's 5 uh, steps usually, or the process: pre-delivery preparation, then birth to resuscitation, then transport to NICU. In NICU, we have to ventilate, put lines, get an X-ray done, start TPN, IV fluid, medications, NICU. So pre-delivery preparation can be can be around 20-30 minutes. You have to discuss with the family, counsel, you have to prepare your equipments, and keep warm, warm ready, for the maintenance of temperature. You have to keep things ready. Then until birth till resuscitation, we have 10 minutes time. 5 minutes time for the transport to NICU. When the baby is in NICU, connect the baby to the ventilator, start putting line. That takes around, in golden hour, about 15 to 40 minutes. And then in the last 15 minutes, you can get an X-ray done, start TPN, and all, or whatever medications needed. So I'll go by step. Pre-delivery preparations, you got information that there is anticipated probable delivery with complications. You get your team, assign a specific role, who is for resuscitation, who is for cardiovascular, who is for medications. Then prepare equipment as per gestation age. Is the baby is less than 34 weeks, you have to special take care of the temperature, appropriate size endotracheal tube, appropriate size laryngoscope blade. Similarly, inform the NICU that then a preterm baby is getting delivered. We have to follow the golden hours to keep the equipments ready, set up ventilator in an ICU, inform pharmacy for medications, radiology for incoming golden hour admission, just to be prepared. So whatever medication you need, it is readily available. Discuss the collection with blood from the cord with your team, blood gas, complete blood count. If there's RH incompatibility, you might need Coombs test and bilirubin as well from the cord. Then counsel the parents that these are the complications are going to happen, how we will manage this, will be a timeline. In brief, not to overburden them with a lot of information at that time. Then you have to arrange things in DR. You have to check equipment functioning, adjust delivery room temperature as per NRP between 23 to 25 degrees Celsius. Turn on the warmer, ensure warm bracket. If you have facility of thermal mattress, activate just before the delivery of the baby. If the baby is less than 34 weeks, open a plastic bag, sterilely deposit in a surgical feed to receive the baby directly in that. Check your resuscitator, appropriate size mask should be there. Set appropriate settings based on the gestational age of the baby. Set appropriate suction pressure for routine suctions. Now baby is delivered. You follow lead resuscitation as per NRP. Receive the baby in a plastic sheet. If the baby is a candidate for delayed cord clamping, perform at least 30 to 60 seconds of delayed cord clamping. Place the baby on pre-warmed mattress. Follow the steps of resuscitation as per NRP. I will not go into detail in resuscitation. So do resuscitation, use pulse oximeter, target oxygen saturation, maintain pressure, maintain adequate seal when you are giving positive pressure ventilation. If indicated, intubate. Uh, if despite giving positive pressure ventilation, there's no respiratory effort, and if you need to do chest compression, ensure that 100% FiO2 is given while performing chest compression. And in case baby developed respiratory distress, start CPAP, start respiratory support in the delivery room, and then shift the baby to an ICU. That will usually from birth till 10 minutes. This resuscitation is respiratory stabilization and shifting. So distracts 5 minutes for shifting. Shifting two concerns mainly during the shifting. One is the temperature and continued respiratory support. Make sure you shift the baby, whatever facility you have available in a pre-warm transport incubator. Monitor the baby during the transport, and on inform the NICU that we are on the way. Keeps everything ready so that the things doesn't get delayed. That should take, depends upon your location, 10 to 15 minutes. How far is your NICU from the delivery room? And then in NICU, you have to ventilate. Uh, you have to do initial assessment, weight done, connection to the ventilator. Is there as per the protocol to give early caffeine? You can give caffeine or wait as per your NICU protocol. Nowadays, people are going for delivery room caffeine, their quality initiative study, feasibility studies, but still you can, there's still not in protocol. We can wait for caffeine to start. Always follow gentle ventilation strategy. Volume target ventilation, always the best, because volume is the main thing which cause lung injury. So titrate the volume as per tidal volume according to the weight of the baby. Start dextrose as soon as possible. Put lines. Take necessary uh, samples. Check position. Nowadays, people are doing ultrasound to check the line position. If not, if facility is not available, you can just based on X-ray, and then can start TPN immediately. In golden hours, it should take around 15 to 45 minutes. Then last 45 to 60 minutes, give other medications if the baby is a candidate for early rescue surfactant, which can be given up to 2 hours of life. But if it's possible, you have done other things you can give in the golden hours also. Administered antibiotic in the golden hour after obtaining blood culture. Administer vitamin K, cardiovascular support. Monitor the vitals. Give If the baby has shock, give normal saline bolus and start appropriate inotropes based on the probable etiology of the shock. Avoid rapid IV boluses for fluids and medication. In delivery room, if during resuscitation bolus, you can give over 10 minutes, but if in an ICU, if you need bolus, should be at least between 30 to 60 minutes, guided by uh, vitals and lab values, as well as facility of echo is point of care ultrasound is echo is available. You can give boluses based on that. Document whatever interventions you have done. Ensure proper temperature and humidity settings in the incubator. Document all the events and then you counsel the parents. What are the chances? What intervention you do? What did what is the expected morbidities, and how long the duration of a stay will be in ICU, and take appropriate necessary consent. This is just a brief flow how to go ahead in golden hours. Now, I will enumerate each interventions in detail. If you go see golden hours, there is antenatal counseling, team briefing, then respiratory care, cardiovascular care, delayed cord clamping, monitoring, communication, taking care of the nutrition, prevention of sepsis, and investigation. So your counseling will be based on what is the expected gestation, what is the gestational age of the baby, what is the estimated fetal weight, gender, did the mother receive, is it a singleton pregnancy or multiple pregnancy, did the mother receive antenatal corticosteroid, if received, how many hours, is it an adequate steroid, is the mother received neuroprotection with magnesium sulfate, even 3-4 hours before the delivery, if give steroid, it can be helpful, but ideally should complete the course of antenatal steroid should have completed at least 24 hours before the delivery. You should provide the parents with the data according to gestation age from your center so that they have an idea what's going to happen at this age stage. Then you assemble your team, assess the risk factors, identify your team leader, anticipate the problem, delegate appropriate tasks, and documentation is important as well. So first, after the counseling, the baby is delivered. Now you have to perform delayed cord clamping. So you inform that I am from the ICU team. I am here to assist your DCC, discuss before the delivery. So this is based on the latest N, uh, NRP. If the baby is more than 34 weeks, no resuscitation required. Perform DCC for at least minimum 30 seconds. Best will be up to 1 minute, but minimum 30 seconds. For non-vigorous late-term, preterm babies between 35 to 42 weeks, you can do intact cord milking. If less than 34 weeks, there's no resuscitation required. DCC up to 3 seconds. Between 28 to 34 weeks, you don't have time to do delayed cord clamping, uh, but so you can do intact cord milking, but for less than 28 weeks, cord milking is not recommended by NRP because it can lead to increased incidence of intraventricular hemorrhage. So never do cord milking for less than 28 weeks gestation age babies. So this is an old WHO guideline on the advantage of delayed cord clamping published in 2014. In preterm babies, there are n number of advantages of doing delayed cord clamping. I will not go into detail, just I will specify the important ones. There's chances of less hypotension, less chances of intraventricular hemorrhage, less chances of late onset sepsis and necrotizing enterocolitis in preterm babies, as well as blood transfusion if you have performed delayed cord clamping. How to do intact cord milking? Just it is a manually expressing umbilical cord blood. You move your hand at 3 to 4 times for at least 20 to 30 centimeter section of the umbilical cord at the rate of 10. There's no various. This is the most accepted method of doing cord clamping. You squeeze for 3-4 times at a rate of 10 centimeter per month of a 20 to 30 centimeter of the section of the umbilical cord towards the baby. That is intact cord clamping, cord milking. In special circumstances, if there is abruption of placenta, bleeding, placenta previa, there's no point of doing delayed cord clamping. Currently, according to NRP, there's not enough evidence in multiple gestations, and data are limited in certain conditions. You have to discuss if the baby is IUGR, there's Doppler changes and abnormal placentations in that case. Temperature is the most important intervention which need to be taken care during the golden hour. All babies after delivery should reach to a normal temperature of 36.5 to 37.5 degree as soon as possible. Why temperature is more important? Because the lab took and all, it's done a study in 2007. Admission temperature is inversely related to the mortality. If there's a 1 degree decrease in the admission temperature, 28% chance of increased mortality and 11% chance of increased late onset sepsis per 1 degree fall in admission temperature in an ICU. So chances of hypothermia are more immediately after delivery and during the transport. So at these 2 times, we have to be extra careful for the temperature of the baby. So how you will take care of that hypothermia? As soon as you communicate to your OBGY team that at this delivery room temperature, at least 23 to 20, Indian NRP recommends delivery room temperature 25 to 27. American Heart Association NRP recommends 23 to 25 degrees Celsius. Keep pre-warmed linen. If the baby is less than 32 weeks, don't dry the baby because the skin is very premature. As soon as it will dry, again it will use. Wrap the baby immediately after delivery in polythene bag. The water will act as an insulator. It will help in maintaining the temperature. Use hat, cap, which is it is neglected. Immediately dry the head. Put a cap on the head. Thermal mattress, if it is available, activate just before the delivery. Wrap the baby in a sheet and put thermal mattress. Transport the baby in a pre-warmed incubator if available. Whenever you need to give oxygen in any form, it should be heated, humidified. Never give cold oxygen or any for resuscitation or ventilation. Pre-warmed IV fluid, new concepts mainly it's still neglected, but people are using it in an ICU. So your saline, dextrose should not be cold. You should be used in a pre-warmed and then infused for the babies. So in delivery room, if you say the room temperature adjusted 23, 25, humidified to 100%, heated to 37%, oxygen through humidifier. There's a radiant warmer. Baby is wrapped in a polyethylene plastic wrap as a exothermic mattress. A baby is placed on under exothermic mattress with heat. This is the interventions to improve thermoregulations after birth and delivery room. How each one acts if you have a uh, uh, babies under radiant warmer, it prevents convection, it maintains heat by radiation, plastic wrap prevents evaporative heat loss, and exothermic mattress act by heating by conduction. So next steps after temperature maintenance, the respiratory support. So respiratory support, when you do resuscitation for term babies, use 21%, preterms 21 to 30% oxygen, because oxygen is a drug used as per requirement. You target saturation as per the NRP. If you're using oxygen, use heated humidified. Perform T-piece resuscitation. AMBU, Self-inflating bags are used only as an emergency. If you have a T-piece, it's always better to use in place of bag and mask ventilation. If the baby is in respiratory distress, start CPAP in the delivery room. Give early rescue surfactant, caffeine administration, and gentle ventilation for the in the golden hour. So follow target oxygen saturation. No need to give less oxygen or more. If at 3 minute target saturation is 75%, that is totally fine. That is acceptable. 72. So don't uh, give oxygen just to reach saturation up to 85-95% within 3 minutes. Less than 35 weeker, you can go. You can start with 25%, even up to 30%. Whenever uh, resuscitation is anticipated, you connect pulse ox. If there is cyanosis, monitor. Whenever you are giving supplemental oxygen, connect pulse oximetry. Whenever you are initiating positive pressure ventilation, you connect pulse ox within 1 minute of life. TPS is a flow control and pressure limited device. It's easy to use, preferred by both experienced and unexperienced. More accurate PIP and PEEP you can generate compared to bag and mask ventilation. More stable tidal volume delivery. So if it is shown that when you use TP resuscitation, it's a better survival without major morbidities. So if the facilities and finance is not an issue, if you're using bag and mask ventilation, shift to the TPs to provide better ventilation to your babies. So if uh, if after resuscitation a baby developed respiratory distress, delivery room CPAP. Dr. Alan Job in long time back, he said, there's nothing more dangerous for a preterm lung than an anxious physician with an endotracheal tube and a bag. And there's lots of, what is the advantage of giving delivery suit? What do you do if the baby is breathing spontaneously but has a labored breathing? This is a time to give CPAP. So why CPAP? It maintains functional residual capacity, reduces the need for intubation, reduces exogenous surfactant, reduces, if you start delivery room CPAP, total number of ventilator days, morbidities, bronchopulmonary dysplasia, use of postnatal corticosteroids, all will be reduced. Deliveries, it is like you imagine a balloon which is partially inflated. It is easy to inflate a partially inflated balloon compared to a totally inflated balloon. If you're giving a delirium CPAP, your lungs are partially inflated. It is easy to ventilate them compared to a totally collapsed lung. That's why delivery room CPAP is a very important. Never shift a baby in respiratory distress from labor room to an ICU. Then early rescue surfactant, we should be given within 2 hours. If possible, give within golden hours. If you have expertise for minimally invasive surfactant therapy or least invasive surfactant therapy, you prefer that. If not, perform insure, intubate, give surfactant, and extubate. What surfactant? As per the studies, if you have a facility for poractant, give 200 mg per kg because it's better than 100 mg per kg of poractant and 100 milligram per kg of Bractant. Indications, if the baby requiring FiO2 more than 30%, CPAP pressure more than 6. If lung ultrasound or excess of RDS, give surfactant. This is just an image showing how they give Lisa. Baby, it is a mannequin connected to a CPAP. They are giving surfactant through a tube direct angiocat directly inserted in the larynx. Gentle ventilation, early use of CPAP, avoid anything which leads to lung injury, use volume target ventilation. Don't target F of initial CO2s as 35, 40, up to 50, 55 acceptable. Always reach a target, always limit to a target saturation between 91 to 95%. Any saturation above 95%, you is you are giving more oxygen. Any saturation less than 91% should not be tolerated. How you will know? You set alarm limit your pulse oximetry, set alarm limit at 90%, set alarm limit at 96%. So you're always will be in between 91 to 95%. Extubate as early as possible. Prefer non-invasive ventilation, either CPAP, non-invasive positive pressure ventilation, or heated humidified high flow nasal galvana. How you will decide which support, how much is the respiratory stress. This is the oldest course since 1970s. Is very helpful still on until this date. You use Silverman-Anderson scoring system for pre-terms and Downey's score for term. Use that habit of using SAS score and Downey's score to categorize your level of distress, and accordingly you decide about the respiratory support baby need. So this is just I'm showing for the purpose of conveying. Use Silverman-Anderson score for preterm babies and Downey's score for term babies. How you will support the cardiovascular system: adequate ventilation, if required intubation, you do chest compression if needed, if required adrenaline, give adrenaline, access to the venous as soon as possible. If you are giving, important point to note, if you are giving bolus of normal saline during resuscitation, time is 10 minutes. But if you are using in an ICU post resuscitation, bolus should be given preferably smaller the baby, longer the duration, between 30 to 60 minutes. Guide it. If you have a facility of functional echocardiography, look at the IVC filling, and accordingly you give bolus. You start vasopressors and inotropes early, give PRBC if indicated. So the decision of this is a very, although very busy slide, but just the purpose of me to all inotropes should be based on the etiology. If you see a low blood flow stage, the three possibilities: either the systemic vascular resistance is low, there is increased leakage, it means low diastolic blood flow, or low systolic and diastolic. Based on your etiology, you have to decide your inotrope. If the filling is a problem, improve filling, give NORAD, give dopamine. If afterload contractility is a problem, give milrinone, give dobutamine. If low systolic and diastolic, preferred medication will be adrenaline and hydrocortisone. So inotrope based on the etiology of the shock to be given. What are the targets? Heart rate should be within normal range, normal capillary refill time, palpable peripheral pulses, normal systolic, diastolic blood pressure as per his gestational age, follows the Zubrow's chart for the gestational age, normal skin color, normal extremities temperature, normal perfusion index, lactate. These are our targets of, if these targets are maintained, it means your cardiovascular supports is adequate. This is a Zubrow chart between, always follow the blood pressure based on these charts. Then next comes the nutrition and prevention of hypoglycemia. Babies are at risk. Small for gestational age babies, premature babies, sick babies, babies with perinatal asphyxia, infant of diabetic, they are risk for nutrition should be started, because glucogenesis will take some time to establish. Preterm infant, small for gestational age, they are not able to generate their own glucose. So support to the nutrition is an emergency. Start IV as soon as possible. Start dextrose. Start TPN in golden hours if indicated. Check blood sugar within 1 hour, within golden hours to act accordingly. Target blood sugar vary, but any point of care 45 milligram is perfect. Irrespective of the symptoms, if baby needs bolus, give bolus of 2 ml per kg. Check in 15 minutes after starting GIR, then hourly till start. Once bolus given, don't sit on the bolus. Immediately after bolus, start glucose infusion rate of 6 to 8 milligram per kg per minute, and keep monitoring blood sugar. Sepsis, as always, the role for sepsis started from the delivery room. Hand washing, most important intervention. Whenever you ventilate, you put a line, you put a surfactant, you follow your sepsis protocol. If indicated, give antibiotic in the golden hours. Investigations based on the clinical status and antenatal risk factor. Blood gas analysis, very important for a preterm baby with RDS or any baby with birth anesthesia. Chest X-ray. Now, ultrasound is very common in NICUs. Use USG lung if you have expertise. Use USG for the line, for endotracheal position. Also, people are using ultrasound. Blood culture before starting antibiotics. Cord blood, most important if you're suspecting perinatal asphyxia. If you're not able to take cord blood, do blood gas within 1 hour of life. Communicate to the family, counsel the family, what has been done, what is the further plan of management, whatever concerns they have, answer patiently. Document everything what you have done, document the counseling, take necessary consent for all the procedure, update the obstetrician about the condition of the baby after you have finished the golden hours. Various studies are done over a period of time. First, they have noticed increased admission temperature, decreased chance after using golden hours. decrease incidence of retinopathy of prematurity, decrease IVS, decrease bronchopulmonary dysplasia. So increase reduction in severe IVH outcomes. So that's the purpose of doing golden hour. You can collect data how as a QI in your NICU, was the room temperature was maintained, what the warmer was preheated, was there warm blankets available. You can improve your uh, care by using a QI method. Take home message from my presentation. It first do no harm, primum non nocere. This is the for newborns. Whatever you do, it should not harm the baby. Use golden hour as applicable to your NICU. All of the interventions will not be possible. Whatever possible, keep checking and keep improving in your NICU. Thermoregulation, most important during resuscitation and transport. Avoid using bag and mask for ventilation unless it is an emergency. Use TPs, DRC-PAP as early as possible. Don't delay use of surfactant. If it's early rescue surfactant, rescue till the lungs are fully collapsed. Consult parents before and after the start. Thank you.
Thank you very much, Dr. Athar. As always, I'll await some queries from the audience if there are any before I move on for a discussion amongst ourselves. I did not notice any questions posted in the chat box. While I request the audience to unmute themselves and ask if they have any questions to the speakers. While we are waiting, I can open the discussion with Dr. Sandeep. I do not see any coming by. Okay, Dr. Sandeep, going by both, there are some overlap areas between both the speakers. So I would want you both to enumerate the challenges you encounter in, as the first speaker, focus on asepsis. What are the challenges you face in this area? And parallelly, what are the challenges we face in golden hour implementation? So Dr. Sandeep, it's as simple
Yes,
as a single word, but it's a whole lot of
I I think
infection control that happens behind. So the
yes.
challenges and how you conquered, and give us the overview of what messages we can take from your experience there.
I think the biggest challenge is outbreaks of infections in the NICU. Time and again, we see a lot of episodes of late onset sepsis in our NICUs across the world, whether it is India or Bahrain. And time and again, the problem has been that whether there is one baby who comes as an outborn with infection and the other two or three babies in the close vicinity are likely to get affected by that. So, our problem basically is one, infections which keep on happening time and again are posing problems to our other babies. So infection control is a challenge. We have to work as a team, whether it's hand hygiene, use of bundles, adequate nutrition, use of mother's milk, minimize the use of long lines, early enteral feeding, um, having a strict antibiotic policy, surveillance, audit keeping, and preventing antimicrobial resistance. I think these are some of the challenges which we keep on facing time and again. What we really tend to do in our own unit is practice kangaroo care, exclusive mother's milk use, less and less lines insertion, more non-invasive than invasive ventilation, and all these things to some extent help in preventing infections. Use of bundles like CLAPSI, VAP, and smaller babies, the nurse and patient ratio has to be all adequately placed, because that is another challenge, because the hospital administration often are having constraints of nursing care. Sometimes the nurses do overtime, and that again is a problem. So we have to look at all those aspects. So it's not one thing, one magic bullet that can treat or prevent and reduce the episodes of infections. We have to have all these things in place. so that we reduce the burden of sepsis in our country.
Yes, the golden hour happens to be one such bundle too. Uh, Dr. Athar, you can tell about the challenges you encounter in your golden hour strategy. What are the QI markers that you are tracking, and then what would you give a message for the audience here?
So when the delivery room and ICU is busy, you don't know how fast the time pass. So sometimes you are managing at 2 hours and pass, still you are not able to do the basic things. For me, it starts with delivery room, maintaining temperature, how much oxygen you are using, targeting. People have a habit, oh no, baby is dusky, give oxygen, give oxygen. Oxygen should be based on the targeted oxygen saturation table. If the baby developed respiratory distress in any form, start respiratory support in the delivery room and then shift the baby. Don't wait, no, it will improve. So temperature maintenance, use oxygen as per required, and respiratory support. Starting respiratory support in the delivery room is one of the important thing which we should focus mainly on. In an ICU, role everyone should be aware, everything for their roles, which person is for medications, which person is for line, which person is for investigation. That distribution depends how much manpower you have, but for me, temperature maintenance, starting CPAP support as early as possible are the main target as of now.
Thank you, Doctor. Shifting our focus to sepsis. Later in pediatrics and adults, the focus of defining sepsis and its outcomes and the mortality is basically based on multi-organ dysfunction and shock. I didn't see much of shock presented in the case scenario posed by Dr. Sandeep. So, how often do you encounter? Is it like our management lineages become superior not to encounter is a commonplace? And I didn't notice either of you using focus as a tool in your handling neonatology, golden hour tool, as well as Dr. Sandeep's conversation. So, can you touch upon septic shock
Yeah, I think,
and
madam,
focus as a tool?
yeah. So, well, basically, what is happening is we have to look at newborns with a clinical eye. All the other modalities are ancillary and supportive. One should not diagnose neonatal sepsis on focus. God has given us eyes, ears, brain, and the vision to help diagnose neonatal infections. We should not make focus as a primary modality of diagnosing neonatal infections. I mean, that's a very clear message that I want to give all of you. My teachers taught me to diagnose sepsis by looking at the history, clinical examination. And that is how I would look at sepsis as a diagnosis. It is a clinical diagnosis. Coming to shock. Well, we all know neonatal infections can cause shock. The reason why a neonate will go into shock is three things. One, whenever you have infections, you are likely to have third space loss and capillary leak. And because of capillary leak, there is going to be decrease in preload, and therefore the baby will have tachycardia, poor pulses, poor perfusion. So if you have shock, maybe a bolus of saline would help. Second, early onset neonatal sepsis with shock is a distributive shock. So there is decrease in preload and the peripheral vascular resistance, which is going to cause vasodilatation, and the baby will go in shock. The insult continues, there is systemic inflammatory response syndrome, and the baby is then going into a cardiogenic shock. And that is a late pickup of neonatal sepsis with shock. The myocardium is not pumping well. Look at acidosis, hypoglycemia, hyponatremia, hyperkalemia. Rule out all those factors. If you have a cardiogenic shock, the drug of choice is dobutamine or epinephrine. So, predominantly, if you have sepsis and shock, the drug of choice would obviously depend on the pathophysiology. Point of care will help you pick up a IVC which is full, then don't give bolus. Heart which is not pumping well, give epinephrine. Catecholamine resistant shock, maybe one could use a low dose of steroid. Correct the underlying metabolic acidosis, because if you have a pH which is less than 7.25, your epinephrine, norepinephrine, dopamine, dovitamin, vasopressin will never act. So coming to the bottom line of all this, shock, sepsis, early onset shock is because of capillary leak and decrease in the preload, and late onset sepsis with shock is because of cardiogenic element, and then what that accordingly. It is as simple as that. I think we all try to make things difficult, but we as clinicians should make the medicine and the management look simple, and it is really simple if you apply your common sense in managing a baby. Fancy investigations are more of your guidance and fine tuning. They will not and they should not replace the human factor in managing a baby. That is my message.
Yeah, our we seek investigations when they are subtle and we cannot probably make judgment clinically, occult, sepsis or so, what we are talking about. So we understand that clinical observation becomes a tool. What may not be apparent at one go, we will have to use another tool of giving it time, if it's asymptomatic, giving a time and observation, that itself becomes a tool in a diagnostic tool. But shifting a focus to certain diagnostics, how about procalcitonin? What is the current evidence and what is the utility in neonatology? IL-6, what are the biomarkers and what is your take and what's the evidence?
If you look at all the new and the old biomarkers, they are basically, there are some early and there are some late. The early ones are IL-6, there are TNF-alpha, procalcitonin, presepsis. The late one, and CD16. The late ones are obviously CRP. Now, what we need to understand is that early onset biomarkers are basically to help you pick up that this could be possibility that there could be infection. But a high PCT, I'll give a scenario. If you have a baby who is unwell and the PCT is normal, do you think we are not going to treat that? The answer is yes, one would still start antibiotics. So my message here is that don't use biomarkers to start antibiotics. Use the biomarkers or the sepsis screen, which is combination of 2 or 3 parameters, to say that I have started antibiotics. The baby is well. Can I stop the antibiotics? If 2 biomarkers or sepsis screen is negative, well, I can stop with some confidence that this is not going to be infection. So the message here is that don't use test to diagnose sepsis. Use test to rule out sepsis. Because no one parameter is going to be 100% foolproof today to say that this is sepsis and this is not sepsis. If you have a sick baby, unwell baby, I think we should start antibiotics without wasting time. And it has been shown, the earlier you institute antibiotics, the better are the outcomes.
Golden Hour emphasized that as well.
Yes.
Yeah.
So we should be absolutely aggressive, judicious, but I think we should also have a inclination to stop when the baby is well and the screen is negative.
Yeah, the message is clear. The biomarkers have their utility probably in stewardship of stopping antibiotics, as you're suggesting, as well as ruling out, not ruling in. Another investigation profile
Actually,
that I want to...
Dr. Vanita, the procalcitonin actually, the main study was the new PINS trial. It was procalcitonin guided decision in significant reduction in the duration of antibiotic. So starting antibiotic in that study also was not based on procalcitonin. When they have seen 2 procalcitonin is normal, then they have stopped the antibiotics. So as Professor Sandeep said, starting is never based on procalcitonin. Of course, it will help, but duration of antibiotics was you can stop based on your procalcitonin values. That was the original studies which became famous and everybody started using procalcitonin. Neopins trial, it was.
Yeah. How often do you use to stop it? Stop antibiotics in your practice? Is it helping to shorten the duration of antibiotic use?
Yes, if procalcitonin is normal, baby clinically better, you can safely. Of course, you have to see clinical scenario as well. If clinically baby is okay, procalcitonin is normal, you are safe to
Yeah, we have a stipulated
new antibiotic
14-day
as early
course
as possible.
for culture positive. For culture positive sepsis,
That is a
there
different
are various
scenario.
studies ongoing
Yeah.
to cut short the duration.
There is some data
Is
about
procalcitonin helping here?
there is some data about short versus long course of antibiotics, and I think 7 to 10 days is reasonably safe in uncomplicated culture-proven infections. That's what it's a non-inferiority trial, and if you look at the meta-analysis, probably 7 to 10 days may be reasonably safe.
There
Non-meningitis.
is a ICMR study going on is there anything valuable coming up there? Some more evidence,
Yes, madam.
probably
Some more
preterm.
evidence.
Yeah.
Some more evidence. Yeah.
Yeah, another question regarding diagnostics. Though your emphasis has been clinical, I have another question. What is the status of molecular testing in the PCR-based tests, and what is the status? And I'm sure most NICUs are utilizing it. And what's the position of recommendation that you would suggest?
Well, we are looking at newer and newer tools and diagnosis for neonatal infection. It's the genomics and the omics. It is still quite preliminary in terms of how is it going to help our babies? Well, people have started sending the biofire. People have started looking at doing the genome-based diagnosis, and the turnaround time may be 18 to 24 hours, because the cultures most often are coming negative. We are not using it routinely in our NS. Let me say that, because number one, it's very expensive, and maybe today it is more of a research tool rather than a clinical utility tool. But if you have a baby who is quite sick, not improving, not responding, you don't know what the organism is, one would think of doing these tests in one-off case, but not as a routine protocol. I think we need to understand the cost constraints and the benefits that we are going to look at.
And the blood biofire, you need a culture to
Yes,
do a biofire as well.
biofire also. So
But it is of utility in assessing the CSF. You can just send for a biofire where culture has not grown anything. You might still get valuable information in situations like that. Okay, thank you, doctor. And as always, culture negative is a challenge. Culture negative sepsis. How confidently have you been able to shorten the duration of antibiotic and
I
stopping
think,
the
madam,
antibiotic?
we really are having that complex problem of stopping the antibiotics sometimes if the baby is still sick and the cultures are negative. Well, the carry-home message that I would like to give everyone is that we need to look at the patient. If the patient is well and the culture is negative, stop. If the patient is unwell and the culture is,
Stop by 36 hours, 48 hours.
I
How
would start
soon?
at 40 to 72 hours. We stop at 70.
Okay.
And if the culture is
And
negative and the sepsis screen is negative, I think we can stop with reasonable confidence the antibiotics. And if the baby is unwell and probable sepsis, normally we would stop at day 5.
yeah, but if culture has not grown, would you pursue on the same antibiotic, or would you make a change there if the
We
child
would
is
continue
unwell?
on the same antibiotic unless there is a clinical worsening.
Okay, thank you, doctor. Now the golden hour. As I asked, what all have you in your respective NICU situations achieved in the golden hour? Have you been able to? Is it different
Dr.
for inborn protocol, outborn protocol? Are there differences in golden hour? Obviously, it should be different. And what are the challenges you face in your respective situations?
No, I did not
And
get your question.
I would ask you about focus. How would you use? No, I was asking, would the strategy be different for an inborn baby and an outborn baby in a golden hour strategy?
See, golden hour is basically if you have been informed about a delivery who is going to be ELBW and VLBW. So mostly it is for a uh, for emergency thing in hospital. For it will be not be possible for an outbound because it comes as a shock or other scenarios. So mainly uh, all quality initiatives where when you anticipate a preterm delivery, then how you prepare. All golden hours has been done based on that. But as a protocol, if you come across late onset sepsis with shock, collapse, you want to uh, to do it as soon as possible, support the respiration. The thing is, you have to stabilize as soon as possible with as whether it's a inborn or outborn. The till now golden hour is for inborn babies, nothing as such for outborn, but you would like to stabilize as soon as possible if any baby comes in a septic distress.
What are the outcomes that have been tracked? Have they really proven the utility of golden hour strategy? Are there any studies saying certain things have been achieved because
Yes,
of golden hour
if you
strategies?
see my second to last few slides, there's multiple quality initiative. I've documented only 5, but there are more of them. First, the original one, first one, they found admission temperature better, IVH better, less chances of retinopathy of prematurity. So mainly they have uh, short outcomes as well as long-term outcome. They have compared. They have found that if the baby received surfactant early, the blood sugar was controlled early, of course it will have a long-term complications in the form that uh, uh, bronchopulmonary dysplasia will be less, intraventricular hemorrhage will be less, retinopathy of prematurity. If the oxygen is used properly, then retinopathy of prematurity. So all these golden hour intervention have been documented to reduce long-term as well as short-term complications.
Thank you, Doctor. Do you have questions for each other from your perspectives? Dr. Sandeep and Dr. Athar, you can
There was one
discuss
question
anything
in
regarding.
group, Dr. Someone asked Dr. Vanita, someone asked in the group, I think this question for Dr. Professor Sandeep, day one cell count is a reflection of mother cell count, something like that.
I think
They have
it is
written.
Yeah.
Can
very
you
important.
see in the
No,
chat?
if you look at day
Day one.
one
So
count,
how soon in the sepsis profiling, sex screening, how soon do you do the counts and what's the advocated timing of sending investigations?
it is not the day one count. Actually, you have to look at the charts. Take help of the WBC count charts in a term and a preterm. You've got the Mausino chart, and those charts can give us a normative data of WBC depending on the age in the postnatal period. If you look at the physiology, when you cut the cord, there is sudden surge of sympathetic system as soon as the baby cries immediately after birth. And there is a lot of demigration of the WBC from the vessel wall into the circulation. So the WBC count rises and comes back to normal at the end of 48 to 72 hours. So I would not take the count of 20,000 on day one as equal to infection. Second, a lot of nucleated RBCs can be counted as WBCs. So baby who does not cry at birth will have high counts because those nucleated RBCs come into circulation. So don't take leukocytosis or leukopenia, like mother having PI, the WBC count may be low. So that cannot be taken as an indicator of infection. Look at the chart, interpret the WBC count as per the Mosino's chart and see what is a normative count for that. Corrected nucleated RBCs, corrected WBC count, uh, that would give us a clear picture. So these are things which we have to take into consideration when you look at a WBC count and sepsis.
We have a policy of collecting for blood cultures prior to antibiotic, right? During which time would it be useful to do sample for counts as well, going by these standards that it
I
might
think
confuse the interpretation?
it is a baseline tool that one would see what is the WBC count or the platelet count. But if it is normal, it doesn't mean there is no infection.
So we'll have to trend it again after
Correct.
24
So because the
hours.
WBC count to show abnormality will take another 24-48 hours.
So is it useful not to do it along with
No, you
the
can do,
early
you
blood
can
tests?
do. It is just to for your, suppose the WBC count was also low and there is leukopenia and there is neutropenia. Maybe there could be a role of giving GCSF to improve the WBC count. So I would not say that don't do it, but normal WBC count does not mean that there is no infection.
Interpreted with that
You
perspective.
have to have that,
Okay.
look at the patient and then interpret the report, because all the reports will come abnormal after some time after the onset of infection. They will not come abnormal right at that point that there is Klebsiella in the blood.
Okay. So you may not achieve the leukocytosis
I
that
have
you're
one
looking
question
for at
for
birth.
sir.
Yes, sir.
Professor Sandeep, that's now like at what, as a part of sepsis screen, at what hour and what investigation usually you are doing? Because some people prefer 6 hours, some delay at 12 hours. So what investigation do you do at your center and at what hour of life?
If the baby is unwell, do a blood culture at 0 hours. I tell all my residents don't do CRP at that point because it will come negative. Look at the patient, start antibiotics, start treatment, give a good supportive care. Look at the same baby after 48-72 hours. Your CRP may come abnormal later on. So don't do CRP at 0 hours. We are all obsessed with that CRP, which is actually a useless investigation to diagnose infection. Treat the baby, don't treat the report. And then maybe 72 hours once your blood cultures come, is there a growth or no growth? Do a CRP, you will get a better idea.
So at that time, if CRP is
And
normal,
if suppose I'm not planning to start a baby on antibiotic, then just for the screening purpose, I'm not planning, baby is not as a candidate for clinically antibiotic. So, but I want to screen, at what hour of life that will be the appropriate to screen
If you
for
want to do a
sepsis?
sepsis screen, do it after 24 to 48 hours after the onset of infection. Don't do it at 0 hours.
procalcitonin would be useful earlier.
Yes, madam.
Would procalcitonin be useful if you're doing it
Procalcitonin
earlier?
may help you, but if you, again, I'm telling you that if the baby is unwell, you treat. If the baby is well, don't do PCT and start antibiotics.
No, in the scenario he proposed, would procalcitonin be
Yeah,
helpful where CRP is not helpful?
it is an early marker of inflammation. So you obviously, if you have a high PCT, it will help you that your thinking is correct as far as sepsis is concerned.
Okay. How about IL-6?
We
It's
don't
a
do
common
IL-6.
practice in NIC?
We don't do IL-6 in India. It is more of a research
Okay.
investigation.
Okay. Any passing message you want to give to the audience, both the speakers? Please go ahead so that we...
Yeah. So 3 things that I would like to say if from my presentation. You have a baby who has got some signs and symptoms and history of infection, treat the patient and stop antibiotics at the earliest opportunity. Use your sepsis screen to say that I can stop antibiotics with confidence. And third thing that I would like to say is that use all the investigations, including POCUS, including point of care ultrasound, echoes, lung ultrasound, just to guide your clinical judgment. They are not going to dictate, and don't be a slave of the investigations. Treat the patient on the clinical merit. Treat the patient and not the reports and not the investigations. I think if you follow that, I'll give you an example. People today are, a lot of my residents do echoes. Patient is well and they say that the PDA is 2.2 millimeter. Do I treat that? Well, if the patient is in room air and the duct is 2.2 millimeter, how does it affect the patient? I would wait, watch, observe. There is no need to treat a investigation just because you have found something. If you are less aggressive and more conservative, your outcomes are likely to be better. Because time and again we have seen that you treat a PDA and you suddenly get a gastric perforation. So you have to look at the pros and cons And I think today we need to be less aggressive and more conservative about doing investigations, treatment, because it adds to the cost of care and it might even increase the complications. That's my take on it. It may sound a little bit outdated like an old time person, but probably we have seen that outcomes are slightly better with a lesser aggressive. And as I always tell all my students that less is more. Thank you.
Message taken, Dr. DrAthar, your message.
Yeah, for me, it will be like if you're still using bag and mask, and if you shift to TPs, bag and mask is only used when there's no oxygen source connected or is an emergency when you don't have time to set up your equipment. So shift to TPs if possible, and if you are ventilating, uh, use volume targeted ventilation if facilities are available. And already I mentioned the temperature maintenance, and you start using giving respiratory support from the delivery room. So DRC, temperature control in delivery room CPAP, use TPs in place of bag and mask ventilation, and practice volume target ventilation.
Thank you. So focus on the clinical observation, infection control, ABC temperature, glucose monitoring. So that summarizes almost both the speakers' presentation. Thank you. Thank you both speakers, and thank you audience for your encouraging presence today. I just check for Dr. Mohammed Salman to give the vote of thanks. If I don't see, because he's also not presently available in Bahrain. I'm not too sure if he's here. I'll just, Dr. Mohammed Salman, are you? Looks like we do not have him around. Thank you, Dr. Sandeep. It was really interesting presentation and the discussion following. Dr. Athar, as complimentary to the first presentation. Thank you both. And wait for the next 6 months, probably 1 month we will take a break and then we'll get started with the next routine. Thank you all.
Thank you.
Until we announce the
Thank you,
next
everyone.
coming
Thank you so
CMEs.
much, and good night and all.
Thank you.
All the best.
Good night. Bye.